Good afternoon. I hereby call this the fourth meeting of the Interim Joint Committee on Families and Children to order. As a reminder, please put your cell phones on silent so it doesn't interrupt the meeting. Secretary, please call the roll.
Senator Rocky Adams, Senator Chambers Armstrong, Senator Elkins,
Present.
Senator Girdler, Senator Mays Bledsoe, Senator Meredith, Senator Tishner, Senator Webb, Senator Westerfield, Senator Wise,
Present.
Representative Baker, Representative Kleins, Representative Decker,
Present.
Representative Dietz, Representative Elliott,
Here.
Representative Fleming, Representative Gooch, Representative Rayburn, Representative Raymond, Representative Riley, Representative Rorks,
Present.
Representative Stalker,
Present.
Representative Wilner,
Here.
Representative Wilson, Co-Chair Carroll, Chair Heverin.
Here. It looks like we have a quorum, so we are constitutionally able to do business today. First, this afternoon, we need to approve the minutes from the August 28th, 2024 meeting. Do I see a motion? Okay, I've got a motion and a second. All in favor say aye. Any opposed? Okay. The minutes from the August 28th, 2024 meeting are approved. Okay. Representative Decker, if you would like to introduce your guest, you can at this time.
Thank you. I have two high school seniors with me today shadowing. We have Michael Willis and Avon Young. Would you stand up and let everybody welcome you? Glad to have you. Thank you.
Thank you. Does anyone else have any introductions? Okay, I will take a moment of personal privilege to introduce my constituent, Heather Jones. Thank you so much for coming from Upton today. Very excited that you were here. And I'm going to go a little bit out of order. I want to go ahead and take care of the reg on the agenda just because we do have a quorum. So we have been referred administrative regulations for review. Do any members have any questions on the regulation on the agenda? If there are no further questions, the referred admin reg shall be considered reviewed by this committee. Okay, so our first presentation will be a discussion of the Kentucky Pediatric Cancer Research Trust Fund. Dr., and I'm going to pronounce it incorrect, D'Orazio? Fantastic. Can you please make your way to the testimony table along with your guests, Ms. Mormon and Ms. Jones? Once you get seated, please introduce yourself for the record. If you hit the push button on the microphone, it will be green, and that's how we'll be able to hear you today.
Heather Jones, Citizen at Large, Kentucky Pediatric Cancer Research Trust Fund Board.
Hi, I'm Spencer Mormon. I am a member of the Kentucky Pediatric Cancer Research Trust Fund Board and the Advocacy Chair.
And I'm Dr. John D'Orazio. I'm the Vice President of the Kentucky Pediatric Cancer Research Trust Fund. Thank you for having us today.
Thank you. You can please move forward with your presentation.
Thank you. Do I keep this pushed the whole time?
You, yes, if you're speaking, okay. Yes, so we can hear you.
Okay. I would.
You don't have to hold it. Like,
okay.
Once it's on, it's on.
Thank you.
You're welcome.
Thank you so much. I would like to thank you to this committee for supporting our efforts, and thank you, Representative Heverin, for this opportunity and your continued support of the Kentucky Pediatric Cancer Research Trust Fund. Also, thank you to our legislators, the governor, fellow advocates, and volunteers for making this a reality. I'm so extremely proud of Kentucky for leading the way in state-funded childhood cancer research. Again, my name is Heather Jones, and I'm a Citizen at Large and Awareness Chair, board member with the Kentucky Pediatric Cancer Research Trust Fund. I'm honored to be here on behalf of childhood cancer families, the ones in treatments, the survivors, and our bereaved families. I have fiercely and unapologetically advocated for safer treatments and better outcomes for our children since 2018, and my why for being here is for my son, Evan. He's an osteosarcoma survivor. That's a bone cancer diagnosed in 2012 in his right arm. And thankfully, he is currently a senior at the University of Kentucky studying environmentalism and sustainability and fun. I'm joined again by my colleagues, Dr. John Diorzio from the University of Kentucky and Spencer Mormon from the University of Louisville, and we are excited to be here to represent an update. Let's get started. The presentation. I'm sorry. I knew where it was.
It's down here.
Apologies. So today we're going to give you an overview of the importance of the Kentucky Pediatric Cancer Research Trust Fund. The Kentucky Pediatric Cancer Research Trust Fund was established in 2015 by Senate Bill 82 and sponsored by the Senator Max Wise. Thank you. Your father of a neuroblastoma survivor. This fund is the product of the collaborative and grassroots effort that has been successful because of the work and advocacy of many Kentuckians. I'm so proud to be a part of this. As you see here, our timeline, we're an independent board administered by the Kentucky Cabinet for Health and Family Services. We meet approximately 4 times a year to review grant applications and progress reports. Currently, we have 44 research projects funded, including psychosocial projects, which I'm really excited to have that included in with our research. As you can see here on the bottom, the timeline, 2015 we were established. We got our first appropriations in 2018. We've got appropriations consistently. And then in 22, you can see we got a really generous boost for research dollars. And then 24, we also got another generous boost. And I think the funds are being spent wisely. And Dr. Diorzio is going to continue with that. Our mission is to make childhood cancer a state health priority that provides all Kentucky children access to innovative research, development, and precision treatments with less toxicity while encouraging psychosocial support to navigate complex issues throughout the trajectory of care, including long-term survivorship.
And to help illustrate the importance of the trust fund's mission and work, we do have some childhood cancer statistics we'd like to share with you. Cancer is the leading cause of death by disease in children. Each day in the United States, 47 children are diagnosed, and that totals 17,000 children every year in our country. 80% of children diagnosed with cancer do live at least 5 years after diagnosis, but there are many chronic health conditions and long-term side effects that they do have to deal with. 57% of our childhood cancer survivors are more likely to develop depression. 29% are more likely to develop anxiety, and 56% are more likely to develop a psychotic disorder. In Kentucky, an average of 200 children are told they have cancer each year in our Commonwealth. And according to our Kentucky Cancer Registry, 2,300 children in the last decade, from 2010 to 2019, were diagnosed. And unfortunately, we see a disproportionate amount of brain tumor diagnoses in Kentucky. Unfortunately, we are ranked the 4th highest in brain tumor incidence in our state. But thankfully, thanks to your all's generous support and unwavering lifeline of support for this mission and this cause, we do have some very exciting projects that have taken place, and Dr. Diorzio is going to let you know about.
Thank you, Spencer. So right now there are 44 active projects being funded by this trust fund by investigators from both the University of Louisville and the University of Kentucky. Projects include many kinds of research basic science like bench research, wet lab research, translational research, clinical research, and psychosocial research. We are doing research on brain tumors, leukemias, solid tumors, and therapeutic side effects. And very importantly, this trust fund has led to lots of collaborations between the universities. And so we're talking actually across, 64 and coming together on Zoom and having joint conferences and joint research projects. I would like to just highlight 4 projects. We distributed a list of all the projects that the trust fund is supporting right now, but we've chosen 4 that I think shows you the depth and breadth of what we're doing. So the first one is called Project Inherited Cancer Risk, and I'm the PI of that at the University of Kentucky. And the background is this: about 1 in every 10 children and young adults who comes in with a new cancer actually has a genetic reason why they got that cancer. And sometimes we could tell as physicians and providers, we could kind of smell this out, like there's just too much cancer in the family, or, somebody's getting colon cancer at age 12, which you shouldn't get. But sometimes you don't know. And so this project, Inherited Cancer Risk, is designed to identify these patients, offering them sequencing of a panel of, I think it's 83 to 85 cancer predisposition genes. And it's important to identify them because, as Spencer suggested, 2/3 or more of our patients happily survive. But if you've got a gene still sitting there that you've been born with, you're at risk of another cancer. And so the way we surveillance these patients and treat them and provide counseling to them and their families is modified greatly when we diagnose one of these genes at play. So it's a clinical study to identify and manage children with increased cancer risk. It started at UK in August of 2021. We've enrolled over 200 patients on this. Over 90% of the patients and families who are approached would like to know whether they have a gene at risk, because it could imply things for their other children or for themselves. And we actually have found, I have a couple of good examples, if you want to hear about them after our presentation, where we found something in the patient with cancer that's led to healthcare changes in the family and good saves that way. The next project is also from UK by Dr. Eric Durbin, who leads the Kentucky Cancer Registry. They're trying to tackle the question of why are we so high in pediatric brain tumors? Is it something in the environment? Is it something in the genes? Is it a combination? And so he's developed a consortium between University of Kentucky, University of Louisville, West Virginia University, and the University of Pennsylvania. He calls Accelerate, and I meant to write it down what all this stands for, but it's basically a group of researchers and clinicians and epidemiologists that have gotten together, and they're doing sequencing and environmental studies with the support of the Kentucky Pediatric Research Cancer Trust Fund to try to figure out why brain tumor incidence is so high in our young people here. A lot of what he's and his team have been doing is developing the infrastructure to integrate big data, so big next-gen sequencing data, so that researchers can mine that and try to find out some of the answers here. Dr. Mikey Huang from the University of Louisville Norton Children's Hospital has opened a successful clinical study using a drug called DFMO for brain tumors like medulloblastoma, which is a high-risk brain tumor of childhood. It's a phase 2 trial, so it's well advanced in the clinical study phases, 1, 2, 3, and it's actually open at 17 different children's hospitals and academic centers across the country, where University of Louisville is the hub. Okay, so we're leading the effort in this in Kentucky. 23 patients have been enrolled, and the goal is to find out whether this drug is effective in preventing relapse or further disease progression in high-risk medulloblastoma and relapse medulloblastoma. And last example that I want to share is actually Spencer Mormons from University of Louisville Norton Children's Hospital, and it's called the Psychosocial Roadmap. And this is a very comprehensive program to provide psychosocial support for patients and families. I've listed in the orange boxes everything that this touches: education, emotional, advocacy, neuropsych testing, family support, and so forth. But it's about integrating this with EPIC, the electronic health record that's being used at UL and UK, and providing a psychosocial summary that's accessible and easy for teams to access to inform their care. It documents what's happening to our patients and the resources and services provided so that we don't duplicate effort. It improves care coordination, and it illustrates Kentucky's prioritization of the whole person and patient and their families. When a child gets diagnosed with cancer and their journey happens through treatment, a lot of stuff can happen to families and patients. It's a very bumpy road, and we have to pay attention to this. So, this has led to 3 projects, 5 additional psychosocial providers and researchers to help make this more of a reality. It puts us on the map for leading initiatives in psychosocial efforts, and Spencer and her team have given multiple national presentations that have highlighted this and other psychosocial projects that the fund has supported.
In terms of return on investment, we've had several exciting things that have happened because of this funding. We've developed and revised the Childhood Cancer Action Plan to actually include pediatric cancer in a more targeted way. And we've also included the pediatric oncology psychosocial standards of care into that action plan. We have new treatments now in Kentucky thanks to this funding. CAR T therapy is now offered at Norton Children's in Louisville thanks to you all and this support. This helps children who need this CAR T therapy get to stay home for months at a time instead of having to be relocated to another state far away, displacing their family and all of their supports. So this is a huge development for us here in Kentucky. As Dr. D'Orazio said, we now have a multi-center phase 1 trial for medulloblastoma, the first of its kind, thanks to this funding. And it's based right here in Kentucky. And this brings hope to families of patients with medulloblastomas. This has not ever been researched before, looked into before. We also had a Kentucky Pediatric Cancer Conference come here to Lexington last year. It brought researchers and experts in the field of pediatric cancer from all over the world to Lexington to discuss research and clinical care in pediatric cancer. One of the highlights was that tissue donation is now available for families at UK and U of L. Via an organization called Gift from a Child. So this process in terms of introducing this option for them is now being integrated into the roadmap project, which we discussed before, where we have an electronic health record of a psychosocial roadmap, and now we're trying to bring that into standardized clinical care of introducing in the beginning to families of newly diagnosed parents and children all of the psychosocial standards of care so that they know what to expect in the cancer journey. And we can try to be more proactive instead of reactive in terms of caring for the whole patient, both emotionally, psychologically, socially, along with physically. And we also are now really regarded as leading the nation in championing support for childhood cancer. New Jersey just passed childhood cancer legislation that was modeled after our state in 2021. And just last week, we had 2 representatives from Kentucky, Dr. Durbin and Dr. Ferguson, represent our state at the White House at the Cancer Moonshot meeting. And in terms of future directions, we want to continue having a positive impact for children and young adults with cancer in Kentucky through this research, this collaboration, the discoveries, and then enhanced clinical care. We want to continue building collaboration and interaction between Norton Children's and University of Louisville and University of Kentucky. When we started this years ago, we honestly started sitting at separate sides of the table, barely looking at each other, knowing each other. Now we truly are a collaborative effort, a team, really consider each other somewhat a family in trying to really support and drive this mission together. And we're serving as a national model now for how other states can approach childhood cancer research and support.
So again, thank you so much for this opportunity. Thank you for continuing to fund this bill and support our efforts. As you can see here, we've got a lot of wonderful projects and great things that are happening in our state, and I'm so proud that we're leading the way in such an important effort. What questions do you have?
Thank you all. What a great presentation. And I want to talk about how advocacy matters because Heather has come to my office since I've gotten elected to talk about this. And so, you know, it's when I was planning out my interim schedule of who I wanted to elevate, she was on the list because she comes and meets with me and educates. And so advocacy is so important for so many reasons. But I appreciate you being here today and getting this great presentation together with your colleagues. Senator Wise.
Thank you, Madam Chair, and thank you for having this as a presentation today. And I'll try not to get emotional. You know, anytime we pass legislation, people always look back and they say, what was the most important bill you passed while you were here? And, you know, we've all been blessed of passing some really good legislation, but it's also very comforting to see the collaboration and the advocacy of the work you're doing. When you do something like this, going back to 2015, and to see where it is today, it's meaningful to so many families and so many people. It's across party lines. And I just want to thank each three of you sitting up there, and there's countless others. But the research you're doing, Dr. D'Orazio, thank you for collaborating between the universities. You know, sometimes it's hard to get in the sandbox and all play together. But you all, in terms of your research and the work that you're doing on this, thank you. For both of you, as mothers, as family members, you've been there. You know what it's like. And you know the stories that are with you for the remainder of your lives as parents, and to see the impact that this has on so many people and what it had on my life. You know, I really, really appreciate everything that's being done. And it's great to see our House and Senate leadership with our A&R chairmen and those that have helped in terms of the funding for this. Because when it first was introduced, where we saw the funding amount, and now where we are and where we're continue to going, that's a significant impact. And those projects right there would not be available if it wasn't for the work of each person in here as a legislator. So I just want to thank all of my colleagues. I want to thank those in House and Senate leadership and others that have got behind this, as well as our A&R chairs and the members of those committees. So it's a very exciting thing to see. I know next also is the Ronald McDonald House, and I'm not going to take up time to talk during theirs, but I want to thank you also as a parent. I stayed there, and I tell you what, when I go through the drive-through now, I'm always chipping in extra cash, anything that I got, because I remember the girls from the Sacred Heart volleyball team that were taking care of our family, providing meals while we were there, and you never know when charities like that until you're affected by it, how much it means. So thank you so much.
I do, before you all leave the table, I don't think that there are any more questions. I would like to take a moment of silence just for the kiddos that have passed on because of pediatric cancer. In Grayson County, we recently had a family they lost a little girl, Georgia May. And so that has been a big part of Grayson County. But we all know someone who has lost their life with pediatric cancer. And so if we can just take a minute to give a moment of silence for that. Thank you all. Thank you all very much. I do. Representative Wilson, do you have a question? Oh, just kidding. Thank you all so much. Thank you for what you all do for families.
Thank you.
Our next presentation will be from the Ronald McDonald House, Charities of the Bluegrass. Mr. Graham, if you could please make your way to the testimony table along with any guests that you have. Another reason why relationships are important. I'm glad to see my good friend Charlie rolling at the table with you all today. I've got to work with Charlie for several years now. Glad to see that he's helping you all at Ronald McDonald House. So if you could please introduce yourself for the record, make sure the green button is on, and you all can move forward with your presentation after introductions are made.
Well, good afternoon, and again, thank you for allowing us this time, Chairwoman Heverin. We're grateful for this opportunity. I'm Nate Graham. I'm the Chief Executive Officer at Ronald McDonald House in Lexington.
And my name is Chelsea McDonald, and I am the Chief Philanthropy Officer at Ronald McDonald House Charities of the Bluegrass in Lexington.
I'm Charlie Rowland. I'm immediate past president of the Ronald McDonald House Board of Directors. To follow up what Nate said, thank you, Representative Heverin, Senator Carroll, and all the members of this committee for allowing us the opportunity to present today on the great work being done by the Ronald McDonald House Charities of the Bluegrass. I also want to thank the Pediatric Cancer Research Trust Fund for presenting as another entity that operates in the space of dealing with childhood sickness. It's important to see their work, and we commend their efforts and wish them the best on all the work that they're doing. A little bit about the Ronald McDonald House. What we do is
Charlie, will you put your microphone a little bit closer? Thank
Sure.
you. Some of us are hard of hearing.
So at the Ronald McDonald House, we serve families with sick children or medical needs to ensure that the children and their families have the support that they need to be there for their child. And our purpose and our mission lead to our vision, that by providing these services to the families, we can assist in ensuring the best possible health outcomes for these children. This is a powerful quote from the founder of the Ronald McDonald House. Something that we have to keep in mind every day is that a family with a sick child is a sick family. The families we serve have left their homes, left their jobs, left other family members, often with very little notice, in order to be there for their child. And so it's our job to make sure that the child is receiving the health care they need, and that the family is receiving the support that they need to be there for their child as they undergo treatment. And so earlier this morning, we had the opportunity to celebrate our 40th anniversary. So the Ronald McDonald House in Lexington opened in 1984. If you're not familiar with the house, it's right across the street from the UK football stadium. So if you're ever in Lexington, if you're ever at a UK football game, we welcome you to stop by and say hello and see the house. We started in 1984 with 14 rooms. We've since expanded to 21 rooms. We're one of 2 houses in Kentucky. We have a great relationship with the house in Louisville. We also have great relationships with other homes that provide services to children and family in Kentucky, including the house in Evansville, Indiana, the house in Cincinnati, and the house in Huntington, West Virginia. So we're excited to celebrate the 40 years that we represented so far, and we're looking forward to the 40 years to come.
So I will continue with that, and I don't think it's ironic in any way, shape, or form that the Ronald McDonald House was started in Philadelphia, Pennsylvania, in a partnership with the Philadelphia Eagles and McDonald's owner-operators in that area with Dr. Audrey Evans, who was a pediatric oncologist. And so I think the presentation that we heard today, and one of the statements that Dr. D'Orazio talked about and Senator Wise alluded to, is the fact that when a child is diagnosed with cancer or any other diagnosis, it's one of the hardest times that you're ever going to go through. And we often say that you really don't want to have to utilize the services of a children's hospital or a Ronald McDonald House, because at that point in time, you know that you're going through one of the toughest times of your life with a sick child. But Senator Wise, thank you for your comments in the fact that when you do have to have it, you are thankful and grateful for the services that are being provided at state-of-the-art children's care at your children's hospital, as well as the care that the family receives at the Ronald McDonald House. And as Charlie talked about, 2024 is kind of a banner year for us, celebrating 40 years in the Bluegrass, serving the families of the Commonwealth. And looking at what the next 40 years have in store for us. But a little bit about what we do. So RMHC of the Bluegrass, Charlie talked a little bit about our mission and our vision, but we have programs that really operate to support families and children as they're going through their diagnosis and their medical care. We have a 21-bedroom house now in Lexington, Kentucky, that serves the children and families. Our primary provider and referring hospital is Kentucky Children's Hospital, and we'll talk a little bit more about some of the other partners that we have as well. In the Children's Hospital, we have our family room that allows a space for families to step away from their child's bed, get a comfortable cup of McCafe coffee, a sweet snack, a salty snack, or just to have a moment of silence with other friends, family, or support around them, to have conversations with their medical care team, those types of things. And then we also have a Ronald McDonald Caremobile that operates in southeastern Kentucky. It's a preventative dental Caremobile that treats students in 5 southeastern Kentucky counties. We're getting ready to celebrate our 20th anniversary with them in 2025. They see an upwards of 2,000 to 2,500 students every year to provide that preventative care that they're not necessarily receiving. But anybody that needs extended care for anything else, we have a partnership with a clinic down there, the Center for Rural Health in Hazard, that we can provide that care free of charge to those families as well. So those are our 3 core programs. We're getting ready to open our second Caremobile in Fayette County, which will be operating in the same way as our Southeastern Kentucky Caremobile, that will be treating students in and around Central Kentucky for their dental needs. And that's in partnership with the University of Kentucky College of Dentistry. So as I said, we launched that Caremobile in 2025. We opened the family room in 2009, and now we have an agreement as of yesterday to begin working on a brand new house that is going to expand our services and our support and our physical footprint for the families and children of the Commonwealth. So each family that comes, it's $125 per night on average per family that we have. And as you can see in 2023, we had just over 6,400 nights with 417 families, saving over $750,000 for the families that are coming. So one of the things that we really want to help everyone understand is that as you're going through that with a sick child, we don't want anything else to matter. We don't want anything else to get in the way of you being present with the care of your child. And we know that health outcomes are better when family is around. And so if we can provide a place for you to stay close, but also for you to get the care and support that you need as a family member, that you're going to be there to help with the care of your child, and that certainly helps health outcomes. It reduces the length of stay in hospitals, and so our services are vital to allowing our hospital and medical partners to do the things that they do. As I alluded to, I talked a little bit about the family room already. Kind of jumped ahead. We had 1,412 family visits. That's not individual visits. We have generally anywhere between 10 and 12,000 people come through our family room each and every year that are receiving, their child is receiving care at Kentucky Children's Hospital. Our Caremobile, again, talked to that. I think one of the biggest impacts that we can see that is since Dr. Nikki Stone has started the program, and in her 19th year, we have seen the untreated decay rates of our pediatric patients fall 23%. When the program started, and this is a wild fact, when the program started in southeastern Kentucky, that area of the world, of the country, had the second highest pediatric decay rates outside of Native Alaskans, and so that's an eye-opening thing, and for Nikki and her team to have had the impact in stopping that and reducing those decay rates at the rate that they have is absolutely incredible. And we've found that if we can take the healthcare to the people and to the kids, that we have a whole lot better outcome. And so we're trying to meet them where they are with that particular program. And who we serve, and so you've heard that we have a Ronald McDonald House in Louisville and a Ronald McDonald House in Lexington. And I think by taking a look at this map, you can certainly see that our mission and our program and our support reaches the entire state of Kentucky and beyond, right? So we have two tremendous hospitals as well as other pediatric medical providers, and so the referrals from Tennessee, Indiana, Ohio, West Virginia, Virginia, and even some international families that we have served are coming to us. And so this is just a picture of who we're serving in the state of Kentucky. It does not take into consideration who we're serving outside of the state of Kentucky. And if you need the support primarily of Norton or Kentucky Children's, you're the sickest of the sick. There's also other hospitals that we referenced before, but our kids and our families are the sickest of the sick. 62% of the guest families have an average median income of less than $30,000. To date, 50% of our guests are NICU, and then we kind of go across the spectrum from there. But we have, as I'm sure many of you are very aware, we have one of the lowest birth rates in the country as far as NICU families and high risk pregnancies from there. And then most of our families are a minimum of 100 miles away from the house. And so each of you have driven the roads of eastern Kentucky. 100 miles coming from eastern Kentucky to Lexington is much further than 100 miles in most other places. So that drive is longer and more stressful. Here on this slide, when we talk about serving families together, we really highlight our partnership with UK Healthcare's Kentucky Children's Hospital, just for the fact that 80% of our families that stay with us are coming from there, just because of their world-class care that they have. But you can see at the bottom that we don't limit our services just to Kentucky Children's Hospital. You can see all of the other places that have the ability that our programs team and operations team work with the social workers and medical providers at these places to provide referrals to our house. And no family has ever turned away, very similar to our Children's Hospital partners. No family has ever turned away because of their ability or inability to pay. That is not something that we even take into consideration. If you need us, we're there to take care of you, no matter where the referral is coming from or where you're coming from.
I get to talk about why it matters, which is my favorite thing to talk about. And everyone has, I loved how you said earlier, your why. It's something that we do as an exercise with our staff, with our board, with our committees to talk about why we are here and why does it matter. It's a question that a lot of people have kind of started talking about more so, and we believe we are here because it is our honor to serve all families from across the Commonwealth. To be able to do this and make life a little less hard for families who are going through some of the darkest times of their life feels like a privilege that we take very seriously. And we know that family-centered care makes a big difference. We know this because the data proves this. Dr. D'Orazio was talking about how now the health outcomes are 80% survival rate with pediatric cancer. When this was started by Dr. Evans, the survival rate was 20%, so it was flip-flopped. 20% survival rate when this house was started, the Ronald McDonald House Charities in 1974. And through folks like Dr. D'Orazio and the research that is leading to incredible improvements in those health outcomes, we are honored to be able to be the helpers to those like D'Orazio, who we call the healers. We know that for leaders in the hospital, family-centered care is a priority. Oftentimes they will tell us, we can tell when a family is staying at the Ronald McDonald House, they're much more able to be an active participant in their child's care. And that's sometimes because they can go home and get a good night's rest. We're very thankful to our partners at Tempur Sealy International, who partner with every house in North America to provide that, but it matters and it makes a difference. And we can see that on the faces of our families who are exhausted at the hospital from 10 a.m. until 6 p.m. every day. They come back to the Ronald McDonald House, and we have groups from across Kentucky who have come and made dinner 365 nights a year because they care and because they know that it matters. So we also know that leaders in over 90% of hospitals strongly agree that the partnership with RMHC enhances their ability to provide family-centered care. It reduces costs to families. As Nate shared, we save families nearly $1 million in 2023 alone. So we're not just a bed to sleep in. Some people will liken it to saying, okay, yeah, I can understand a hotel cost X amount for a night, but beyond that, we provide meals for our families. We provide transportation to and from the hospitals, laundry services, and then again, those psychosocial community supports that are so centered to the emotional and physical well-being of our whole family. This is our impact strategy framework. I love to talk about our purpose because it's caring for families with children. It's a pretty great purpose. A vision for a world where every family has what they need to ensure the best health outcomes, and our mission, which Charlie eloquently shared. But what we're trying to do is increase our capacity because we can't keep up with the demand. The demand has grown significantly for families who need to be treated at UK, Kentucky Children's Hospital, and other medical facilities, especially when we're seeing a huge rise in behavioral health hospitalizations. And so what do those families do when we're the closest proximity to them from Pikeville or wherever they may be coming from is that they have no place to stay? Well, when we're full as a 21-bedroom house, we know that they're sleeping in the hospital parking garage. They sleep in their cars where they can, and that's if they do have transportation. And the alternative would be that they're not able to stay close to their child in this community and they have to go back home. So we know that this is unacceptable. We don't believe that as Kentuckians we're going to stand for this and see this need outpace our ability to provide support for families. So we know that we need to grow, and we look forward to doing that and really looking at the holistic opportunity that we have for this, what we call, continuum of care, before, during, after. Not just looking at our families while they're with us. However, what an opportunity do we have while families are staying with us for 6 months, over 100 days, up to a year, and to say what type of support programs can we educate them with and equip them with so that they can go back to their communities and help educate and bring that back to those communities so that they have a better chance to be a healthy and positive health outcomes for that whole family. They are the decision makers. We're so thankful that the hospitals and the medical providers can provide the care for the children. But it's our responsibility, we believe, and it's a great opportunity that we have to empower our families across the Commonwealth to teach them a better way and let them go back into their communities and spread that word themselves.
And so what is the end goal? And I think the realization for us is the absolute need for growth. We have we like I've said, we've got a 21 bedroom house now. Over the past 5 years, we've had 1,300 families that have stayed with us, a collective of almost 27,000 nights, and 80% of those have come from our great partner at Kentucky Children's Hospital. And then we talked a little bit about the financial situation, how far they're coming from, and those types of things. But I think what we're really starting to notice is we would love to put ourselves out of a job, because if that's the case, then that means we don't have sick kids and families needing to be near those sick kids. The harsh reality is that's not the case. And as our pediatric services continue to grow, we feel it's our responsibility as the Ronald McDonald House and the services that we provide to be able to serve and support in that same type of capacity. And so if you want to take a look at some of the comparisons that you look at, the number of beds has increased at Kentucky Children's Hospital, and we're only looking at Kentucky Children's Hospital at this time, but know that other pediatric services have also grown in their specialties as well. 211%. With a 114% in specialists at Kentucky Children's, and we've grown 24%. And so we are looking at, over the next 5 years, if the needs stay the same, if it remains unchanged, that we will be turning away up to 1,000 families from the services and support of the Ronald McDonald House. And we feel that the calling that we've been brought here to talk about is that's not acceptable, and that we need to make sure that we're doing everything that we can alongside our medical providers to be there for the families that will not only help save the state of Kentucky more money just because the families are close, the length of stays are shortened, and we don't have other issues where families are not able to bring their kids for the care that they need in Kentucky. And so we will end with this. It's another Dr. Audrey Evans quote: "The house is an incredible home environment. It's not just food and beds and clothing. It's an atmosphere of care and support. So it's the epitome of care." And that was from our founding member, Dr. Audrey Evans, over 50 years ago. So, and thank you, and we'll take any questions. And again, Chairman Heverin, we thank you for this opportunity.
Thank you. Do any members have questions or comments? Okay. Senator Mays Bledsoe.
Thank you, Chair, and thank you all for your presentation. I'd be remiss if Lexington didn't speak up and say what a phenomenal job and what an asset it is in Lexington for sure. As you've mentioned, I've had a number of friends on the board. I've had friends who have been served there from outside, and family members. It is a remarkable blessing, which is exactly what you do. The privilege of service is amazing, and you can see it at the house. You mentioned expansion, growth in Lexington. Is that where you see that happening? And then what would be your end goal in terms of what do you see in the next 5 years?
So thank you for the very kind words. So our end goal is, from a physical footprint standpoint, would be 85 beds, which is a 4 times growth of what we have right now, right on the University of Kentucky campus, so that we're centrally located to all of our referring partners and primarily our number one referring partner. As we look at what does the overall growth look like, no, Lexington is not our sole focus. We want to make sure that we're expanding the services that we provide, the support, as Chelsea kind of alluded to, into the communities in which we serve, in relationship with Louisville, as well as our partnerships in Eastern Kentucky with places like the University of Pikeville, the Pike County Health Department, down in places like Hazard. We don't want to come in and be the almighty. We want to come in and make sure that we're building partnerships and having a long-lasting effect. And so, yes, the physical growth will be in Lexington. The programmatic growth will be throughout the state, wherever our support is needed.
I appreciate that, and space is a premium, in that little area.
That's right.
So I'm grateful you would have the opportunity to do something like that. And the growth of the hospital has been pretty phenomenal. I mean, Lexington has continued to be kind of the trauma specialist for severe and acute, not just cancer, but just trauma and health in general. So the need is certainly there, and it'd be great to have an asset that has more availability to serve. So I appreciate it. Thank you.
Thank you very much. And I think I alluded a little bit at the beginning of the conversation is that the University of Kentucky, UK Healthcare, Kentucky Children's Hospital, and ourselves just agreed on a 6-acre site on campus to begin the process of what it would look like to have a larger footprint for greater services in and around Lexington. So thank you.
Representative Rorks.
Thank you, Chair. I just wanted to ask about the hotel program expansion from 2023. Obviously, the best way to have cost savings and the actual continuum of care and care supports is to be in the Ronald McDonald House facility. But as filling that gap with the need, can you talk a little bit more about the hotel program, the partnerships there, and what funding source that comes from?
So I'll kind of start backwards. The funding sources that comes from is our donors. It truly is the folks who come in to support, whether it's the foundations that we work with, the individuals that we work with, or our great corporate partners such as McDonald's. Well, what we were seeing is that we were turning away families. We'd have waiting lists up to 25 families waiting to get into and have our services. And so what our programs team decided to do was to look at area hotels that we could put short-term stays into. So anyone who is going to be there for 2 nights or less. So most of those are our follow-up patients that are coming in for treatments or testing or whatever that may be. We'll put them up into the hotel, which kind of expands our footprint to 28 bedrooms. We have a 7-bedroom lock that we have with our hotel partner. But they can seek the services of Ronald McDonald House. They can come over for dinner. They can come over for laundry. They can do the different things that we offer. But it's just not the same. But it does allow them to be in Lexington and receive the care that they need. So thank you for that question.
Thank you. And our last question or comment will go to Senator Wise.
Thank you, Madam Chair. Once again, thanks for everything you all do. I have a question, though, on the Care Mobile. And you mentioned the partnership with UK Dental School with that. So are you all doing in terms of sealants or treatments, but is there follow-up to that in terms of once these children are seen, are they being referred locally to dentists maybe in that region, or how is that working? I love this concept. I know we've got a lot of mobile clinics and mobile dental units that are out there. I just didn't know about the continued follow-up care for these children, what they're getting after that.
So that's exactly right. We want to make sure that every child that is a part of the program is receiving the preventative care. However, when those exams are being done and we see that there are additional needs for those kids, then we have partnerships with pediatric dentists and other clinics that those kids are referred to, and then in southeastern Kentucky. So that's more specific as to what we're looking to really ramp up here in central Kentucky. We partner. We have the clinic, which is the North Fork Valley, which is in Hazard, Kentucky, that we can directly send them, and our dentist, Dr. Nikki Stone, or other dentists within that clinic will take care of seeing some of the hard things that we're running into with those, and we're hiring folks to kind of help with caseworker and case management and things like that, is that once they're referred, they don't have transportation to get to the dentist to receive the care that they need, and so we're actually developing a program right now where we can follow up with those, and if they need transportation, we're able to provide that transportation, and that really kind of came to us from a story of a child literally missed 18 follow-up appointments, and they needed critical care, but they had no transportation to get where they needed to go, and so where there was a problem, we wanted to come in and into the community and understand what the solution could be and how could we help provide that. So thank you.
Fantastic. Thank you, Madam Chair.
Thank you, Senator Wise. I bet I know a pediatric dentist in Campbellsville who would be interested in a partnership. All right. Thank you all so much for your presentation. Thank you all for all that you do.
Thank you.
We will move on to our last presentation. This might be the best timing we've had all interim. Our next presentation will be a discussion on adverse childhood experiences. Ms. Moody, if you can make your way to the testimony table along with any guests that you have. And then please introduce yourself for the record. You will see the green button on. And then you can get started as soon as you all introduce yourselves.
Great. Thank you so much, Co-Chair Heverin. I'm Shannon Moody with Kentucky Youth Advocates.
I am Darlene Davis Goodwine with Parents Zone Aid Behavioral Health at Kentucky State University.
And I'm Barry Allen, President and Treasurer of the Geens Foundation, a private independent.
Yeah. Make sure your mic's on and make sure it's up to your mouth so we can hear.
Yeah. Barry Allen, President of the Geens Foundation, a private grant-making foundation in Louisville, founded in 1957 by Mr. and Mrs. Geens.
All right. So we really appreciate the time and the work of this committee, especially this presentation will be pretty data and research heavy as the previous two, but we hope you all are walking away with some really clear and solid information that you can then use as you continue your good work. So the request was to talk about adverse childhood experiences, or ACEs. This is probably something that you all have become familiar with over the last couple of years, and if not, I'm going to explain what ACEs are and what it looks like, and Dr. Darlene Davis Goodwine is going to talk about what it looks like showing up in the community especially. But the adverse childhood experiences idea or concept came from some research that started in 1995 and went through 1997 by two doctors that were actually looking at obesity. And what the doctors realized is that the patients that they were treating and the research that they were doing with those patients, a lot of the population had high rates of parents who had substance abuse, especially alcoholism, as well as experience with sexual abuse. So it got them thinking about what it means to experience adversity in childhood or hard traumatic events in childhood, and what that actually looks like in the long term for your physical and emotional health as an adult. And what they realized after doing 17,000 surveys is that there is a clear connection between an experience in childhood that causes significant amounts of stress and later long-term health outcomes, especially heart disease, obesity, substance abuse, and depression. And we see high rates of those things in Kentucky especially, and we will talk about what the rates of that look like in a little bit. But those 10 items that they looked at initially within the research were different types of abuse, physical, emotional, and sexual, neglect, physical and emotional, household dysfunction, mental illness, having an incarcerated relative, mother treated violently in the home and witnessing that, substance abuse in the home, especially by the parents, and then divorce or separation of the parents. So as this started in the 90s, several more researchers started to dig into what the connection was between that challenging time in childhood and later health outcomes in adulthood. And they started to make connections not only to those initial experiences with abuse, neglect, household dysfunction, but then also bullying, community violence, natural disasters, which unfortunately Kentucky has experienced over the last several years, living in foster care, losing a parent to death, community violence, witnessing or experiencing terrorism, and experiencing gang membership. So we know that these experiences in childhood then later influence what your adulthood looks like, influence the way that you thrive and succeed into adulthood. And it's kind of common sense, right? When bad things happen in childhood, if things are not mitigated, if kids are not provided opportunities for supports, in adulthood, they're going to struggle with normal employment, with having relationships. So the research is really clear around that dose response effect as well. The more adversity you experience in childhood, the more times that you feel stress and your body is responding to that stress, and especially in a chronic way, the bigger impact it's going to have on your immediate and long-term health. So a lot of research is now looking at both the experiences of children in their homes on an individual level, as well as within their communities. And on the next slide, I'll show you what this looks like in Kentucky with what the data says. But we know that a lot of challenges that we see in this committee, especially, are on this tree and roots. In Kentucky, we see that 30% of adults have lived with someone who had a problem with alcohol or drugs. We know that 22% of adults witness domestic violence in their homes. We also see that 36% of kids live in high poverty neighborhoods, which impacts their overall ability to address stress, and it affects their mental well-being. This is a chart, and this should be in your packet. I'm not going to go through every single one of these, but what I want you to see is that, unfortunately, Kentucky has high rates of these adversities across the board. We have high rates of children who have parents or guardians who are in jail, who have experienced incarceration. As you all are very well aware, high rates of abuse and neglect. Having a parent who is dealing with a substance use disorder or substance use. So we know that these are big issues in Kentucky, and we also know that these impact not just the parent who is struggling with them, but also the child or children who are in the home as well. And I had mentioned this, but we know that at any time an adversity is experienced, it impacts a child, and it could be short-term or long-term, depending on how it's addressed. But for every time that a child experiences one of these adverse events, it's like a dose response effect. It builds upon itself. So when you have children who experience 6 or more adverse childhood experiences, it can reduce their lifetime, the length of their life by up to 20 years. So this has significant impacts on our kids and families. And we also know that it can be addressed in childhood and in adulthood in order to ensure that we don't have those long-term health outcomes. So I want to talk about what it looks like in terms of cost and what we see in our state. So in terms of taxpayers and what adversity looks like, we know that there is an estimated $14.1 trillion, with a T, $trillion annually spent to address childhood exposure to trauma. And that is with direct medical spending, like at the hospital, within mental health, but then also lost healthy life years, which basically means not participating in the workforce, accessing supports that are often provided by the state with state dollars. We do not have these amounts, which I think we will hopefully soon have the impact and cost in Kentucky. But you'll see in Tennessee, they did a study in 2017 and estimated that they are looking at $5.2 billion in direct medical costs and lost productivity from employees missing work. That's annually, $5.2 billion. In Alaska, they have estimated around $775 to $800 million in annual costs. They looked at it a little bit differently, but calculated Medicaid use, smoking, diabetes, binge drinking, arthritis, and obesity, as those are very clearly connected to that childhood adversity. And there are costs to opportunity for our young people. We know that when toxic stress experienced in childhood is not managed and is not mitigated, we have an increase at the risk of adolescent pregnancy, smoking, intimate partner violence, disrupted relationships, cancer, suicide, heart or liver disease, you name it. The things that we do not want to see happening to our kids, unfortunately, they are at a greater risk for. We also know that a lot of this can be solved by means of positive childhood experiences. Just because you have experienced an adversity in your own childhood, it does not mean that that's fate. It doesn't mean that you are going to end up with cancer or struggle with obesity or substance use issues. But it's really important to make sure that kids have access to these positive childhood experiences. These also have a dose response effect. The more positive childhood experiences, the better it is for kids for their mental health, and the more likely they are to be thriving in adulthood. So these positive childhood experiences, which also come from research, are being able to talk with family about their feelings, feeling supported by family in difficult times, participating in community traditions, feeling of belonging in high school. You'll notice a lot of these things happen on the individual level and are supported through schools, through out-of-school time programming, through good, successful parenting. But there are also things that we can do on a more systems level in order to make these things easier and more feasible for our adults and caregivers. So this is my final slide, and then I'm going to pass it to Dr. Davis Goodwine. But some of the things that I know that this committee sees on a regular basis and would continue to love for you all to consider is addressing housing stability, because what we know is the more stress that our parents and caregivers experience, the less able they are to adequately care for their kids. Improving access to behavioral health services in communities. We know we have seen this over the last several years, especially with the leadership of Senator Wise and making mental health services more available by tying it and connecting that within schools, and as well as obviously the House and Senate who had supported that work. Boosting investment in quality early childhood care and education. Teaching kids how to regulate their own emotions is a strong opportunity for kids to be able to grow into adults who can regulate their emotions and be successful in whatever community or environment that they're in. Ensuring access to concrete supports when families need a hand up, including survivors of domestic violence. We know that those safety net programs are really key in order to addressing stress and basic needs of kids in homes where there are challenges. And we also know that working parents provide a good model. So creating an opportunity to enter the workforce within these supports can create an opportunity for kids to see that in their homes. And then finally, holding parents accountable in ways that minimize the impact of incarceration on children. There are community-based alternatives for nonviolent offenses for parents and caregivers where they can stay in the home, be held accountable for the actions that they took, but also still maintain their work and maintain their ability to parent their child. So I will pass it over to Dr. Davis Goodwine.
Good afternoon. First off, I would like to thank you all for inviting me here. It is such an honor. I am humbled by this experience. I actually start off this presentation from the space of a parent advocate. So I am a small business owner in Frankfort, Kentucky. I have an agency called Parent Zone. And the reason I created Parent Zone is because as an educator, as a psychologist, and as a parent, I realized there were not a lot of resources that focused on providing parenting support. So when you hear about parenting support, I want to specify that that is not the same as parent support. So I start this conversation by anchoring you there because I think it's important as we learn about ACEs, and I'm going to use generally ACEs. When we learn about ACEs, and likely as you learned about ACEs, we learned about it as a concept. We learned about it as this information and this experience and this relationship between the environment and the individual and that facet. What I want to invite you to do today is I want you to center the child instead. Because what is a part of ACEs is the childhood experience. And in order to fully talk about the childhood experience, we must talk about the family dynamic. And in order to talk about the family dynamic, we must include concepts around parenting. Oftentimes there are caregivers in place. Oftentimes there are state systems in place. But ultimately, the presence or absence of parenting is what really creates the opportunity for buffering around this childhood experience in a way that increases the likelihood of positive childhood experiences, which is what we want. So I offer you the individual perspective as well as the systemic perspective. And I invite you to walk with me through a story about Johnny. Johnny is 13. Johnny just turned 13. Johnny now wants to be called Jay because Johnny is a teenager. He's no longer a child. Johnny was what everybody else called him when he was a child. So let's talk about Jay. Jay is a 13-year-old young man whose mom name is Kim. Kim just returned to the home because she's been in recovery. In Jay's life, as you see, I will mess up and call him Johnny as well, because that point becomes important as I get to the environmental spaces that Jay exists in. Because at home, Jay has returned to being parented by Kim. But Jay has spent a lot of time with his aunt and his grandma. Now, what does that look like on a day-to-day basis? Jay struggles with authority. There is constantly shifts and changes in his day-to-day life. So imagine what that looks like for Jay now that he's in middle school. Now, we love Jay's because Jay's funny, he's fun, he's all bright and excited about learning, except when he comes across authority, he struggles. Why? Because of his dynamic with Kim, because of his dynamic with his aunt, his grandmother. So when the teacher calls him Johnny and not Jay, he doesn't know how to regulate his emotions, so he acts out. And so imagine how that catapults and builds throughout his education. This is the translation of what adverse childhood experiences looks like from the child perspective. And this is what I offer you to consider as you're thinking about policy and you're thinking about how to support those young people on that level. Because one of the things that Kentucky has done a great job of is we have looked at putting mental health resources in schools. We've done that. We're looking at preventative care and looking at how to navigate child welfare systems in different ways, in unique ways that support parents. What I'm asking you to do is consider the role of the parent more intentionally, the role of the caregiver more intentionally, because the thing that is missing in this space right now is how do we encourage and empower those who are in the role of parents to do the parenting practices that support and increase the likelihood of positive childhood experiences. So if I bring you to the examples of Jay, see, I did it again. Now imagine how Jay would respond, right? If I bring you to that lived experience of Jay, I ask you to consider what and how are we thinking about these childhood experiences in the arena where we are tasked with making change? What do we do with that? How do we approach that in a way that's comprehensive, that's holistic? It's a privilege to have heard all of these other presentations because I think it's unique in that what we are talking about is not necessarily the medical aspects of this, but the mental health and the psychological aspects of this. So as an instructor in psychology at K-State, my students should be listening because they have an assignment. As an instructor, I talk with them all the time about it's not just about the issue, it's about the impact. And right now, ACEs are having a huge impact on Kentucky families. So as a parent advocate first, as I present today, I am encouraging all of us as a state to consider in what ways we can further support our parents in developing and practicing stronger parenting behaviors that increase the likelihood of these positive childhood experiences. And so I bring you back to Kim. Because while Kim has been struggling in her recovery and trying to be there for Jay, she's calling him Jay because she knows what it means to have a teenage boy, right? She's trying to hear Jay, learn about Jay, but she's struggling too because she's been in and out of his life, intergenerational traumas. It's likely that there was some type of substance abuse in her family history or some mental illness in her family history where those parenting practices were not necessarily passed forward. So now what are the resources available to her to gather that information so that she is then equipped and skilled to increase those positive childhood experiences for Jay? So if I paint the picture for that, if I culminate all of these experiences, that's what I will leave with you. I will leave that with you because I also think it's important as we go back out into the community and we consider that Jay is getting in trouble at school and the teacher has likely tried to call Kim. What are we offering then to connect those resources in the way of wraparound where we're not just focusing on making sure Kim has housing as is important, making sure that Jay has tutoring as is important, but how do we connect and complete that circle where parenting practices are fostered, where it completes this cycle of support, not just in the social aspect, but in the emotional aspect and the psychological aspect. So with that, I close.
Thank you. So I'd like to begin my brief remarks with just a personal, sincere word to each and every one of you, because my admiration and appreciation for those like you who have answered the call to public service began in the 1960s when I served as a page in the Mississippi House of Representatives. And so I want you to know how much I appreciate how you hold in your hearts every day with compassion and conviction the needs and the lives of all Kentuckians, but particularly those that are the most vulnerable. And also my gratitude to you for the way in which you seek to enact effective policies and provide sufficient funding to enhance the quality of life for all Kentuckians. And so I appreciate the privilege of bringing some remarks to you today on behalf of the Bloom Kentucky Coalition of 32 charitable grant makers from around the Commonwealth that have come together as advocates to educate and encourage policies aimed at preventing and mitigating this impact of this adversity in all of its expressions. And I want to particularly thank Senator Wise, who was with us in 2022 when we launched this initiative, and all the ways that you've been supportive. To our knowledge, there never has been a cause in the history of the Commonwealth around which grant-making organizations have moved out of our comfort zones of making grants to charitable organizations in our local communities and into this public policy advocacy arena as an additional component to our missions. We've actually come to the realization that we can't fulfill our missions if we aren't engaged in policy advocacy. And we came to this realization after decades and millions of dollars in grants. Those grant dollars were providing important and needed temporary relief, but were not improving the undesirable and unacceptable circumstances in the lives of those we were seeking to serve. As a result, we came to the conclusion that to effect systemic change required us to move into this realm of policy, to go upstream, and to address the root causes of adversity, provide the necessary support for families, and build resilient communities. Although there were various causes worthy of our attention and action, the case for advocacy around ACEs was the most compelling and the one around which most of our organization's interest in education, health, and equity intersected perfectly. So over the past 3 years, and with the able assistance of Kentucky Youth Advocates leadership, our coalition has been conducting regional listening sessions with parents, youth, teachers, community leaders, service providers, elected officials, and faith-based leaders. In addition, we are conducting research that will inform the public and legislators around long-term solutions to the challenges of poverty, housing, mental health, kinship foster care, and substance abuse. We want to do everything we can to assist you in making informed decisions related to this multi-generational challenge. So please call upon us. We have stories to share from your constituents, success stories that could be replicated, and ideas to reduce the adversities our Kentucky children are facing every day. And let me close with this insight from the late Fred Rogers of the children's TV series, Mr. Rogers' Neighborhood. He made this observation: the future belongs to those who give it hope. Thanks to each of you once again for holding in your hearts with compassion these victims of child abuse and neglect, and for the passion you demonstrate in wanting to make a difference in the current and future generations of Kentuckians, in moving them from helplessness to hopefulness. And we are in this together with you. Thank you.
We're open to any questions if you have them.
We have several, it seems. Thank you. And I do ask, as we're coming up upon 2:30, please be brief with your comments. This is, and then Senator Cassie Chambers Armstrong. Thank you. This was a fantastic presentation. I really appreciated it. I wanted to kind of tee us up for the next meeting I hold in November, and so I think this is a really great opportunity to highlight that. Now, I wouldn't have put you all on the agenda, all of you all, if I'd known this was going to be the Max Wise fan club. Just kidding. No, thank you all. I think this is a big generational conversation. And as you look at us up here, we're all from different generations. And so we might look at it a little bit differently. But I think as we move forward and plan for the future, and I really like what you said from Mr. Rogers, the future belongs to those who give it hope. And I think I look at this as a committee that gives Kentucky hope in our future and our kiddos. And so I'll move on to the questions. Representative Fleming.
Thank you, Madam Chair. And I agree with the chair that this is a very robust. We have a lot of presentations that come before us on various committees and robust information that y'all presented, and we appreciate the data and the enthusiasm as well as the dedication to try to change the dynamics of that and what we're faced with. But I want to bring in a couple of things that y'all need to be keenly aware of that y'all have not mentioned. And this is really go to Mr. Allen and the foundations. But I guess in a one particular way, y'all brought a lot of issues, a lot of challenges that the youth and individuals and families face from a holistic point of view in terms of changing the dynamics when it comes to mental health. And I worked with Representative Wilner and on several boards and trying to change the dynamics of the workforce. If you don't have the workforce in there, you can talk all you want, we can address all we want, but if we got to look at the workforce because there's deficiency in terms of having these individuals that come through the pipeline for scholarships and all that stuff in order to provide those services. And I know from the foundation's point of view, because I've been on them as well as when I've asked for money, it's usually for program type of programs. We need to, and I would like to encourage you to think outside the box and look at more substance in terms of staff for staffing grants in order to do that, to get individuals through the pipeline in order for them to provide mental health services. That's what I think is going to be that's not the be all and end all. But it's very, very important for us to change the dynamics in order to try to get the services out there. So I wanted to see what your thoughts are about the workforce and what you all can do to provide us with some policy decisions, from some funding decisions, because those are two things that are deficient: policy and funding when it comes to mental health. And we need to put more of an emphasis on that, and we have made some strides in the General Assembly, and I'm sorry for being a little long, Madam Chair, but I want to make a point. We made some strides, but we are way, way behind the 8 ball, and we need to continue to go down this path to try to elevate that. So I'd like to hear y'all's comments on that.
I appreciate the question, Representative Fleming. I may be part of your fan club as well by the end of this, because that is something that we've been talking about within our coalition. And I know Dr. Davis Goodwine has got some thoughts on this. A couple of the things that we have considered and would love for this committee to consider is you had talked about creating kind of a pipeline of more individuals in order to staff around mental health. What would it look like to ensure that our federally qualified health centers had staffing that was available to provide mental health supports in places where they are already available, or getting creative around staffing in different parts of the state where maybe there isn't typically mental health services provided but are really needed, and make it more accessible, especially if there's some stigma around accessing mental health treatments. Providing scholarships and stipends for students going through the process to becoming whether it's to finishing their degree or becoming licensed as clinicians. Also providing incentives for folks who are willing to supervise as well. We know that we need really strong, solid supervisors for those students or for newly licensed mental health clinicians in order to ensure that that pipeline is strong and we're addressing burnout before it ever really takes place. Dr. Goodwine?
Yes. Am I? Now I'm on. So I just recently joined the faculty at Kentucky State University in the School of Psychology. One of the goals that I've discussed and why I came on board is because Kentucky has the opportunity to bring forward a master's level clinician's license in the area of psychology. So I came on board so that I can prepare our undergraduate students to position themselves so they can then lean right into and walk right into a master's level program so that they can become licensed. And to further support what Dr. Moody said, we do need more providers and we need more incentives for us clinicians to offer supervision services, because if we're supervising, we can't do therapy, right? So it's kind of like there has to be some incentive and some structure where it allows those of us who are actively on the ground working to shift out of those spaces so that we can allow others to come in. But right now, we are very, very, very much overwhelmed. So we can't come out of those spaces until we can put some other providers in space. And increasing reimbursements.
Yes, and thank you. I think that you will find going forward that more and more grant-making foundations, particularly in our coalition, are going to be more flexible in our grant-making. As a matter of fact, we're advocating among ourselves for more what we call mission support type grants, where, if we believe in the mission of the organization and they have the competency and capability of carrying out their mission, then why wouldn't we just give them the funding and let them use it in ways that they feel they need to, without putting any type of conditions on that? I think you'll see more of that going forward.
Well, that's good to hear. And thank you, Madam Chair. And just a 30-second statement, and that would be, given what we've seen
Real
in the
quick.
public. So, is that okay? Just 30 seconds.
Real quick.
I know this is important. This is important because the underlying
You're wasting
issue.
your time.
Thank you. There's been recent reports of some contracts or the Medicaid's being cut 30% on the MCOs, and that's going to be a really big issue and problem for nonprofits because we are getting squeezed constantly, and we won't be able to provide the service. And you're going to see quite a few of these agencies going out of business, and it's going to cripple mental health services.
We see that every day. Yep.
You hit 27 seconds. Thank you, Representative Fleming.
I'll yield my time.
Representative Deets.
Thank you, Madam Chair. Mike, it's a comment and a question, and really it has to do with family court. 30 years of being a family law attorney, and in the last 5 years of watching some of these words now, emotional abuse, physical abuse, verbal abuse, psychological abuse. I'm going to go back to the word coercive control because I don't see that in here. It's something that I've worked on during the interim with domestic violence. I hope to run a bill that's going to add that to our domestic violence statute. But children can be used by the abuser against the other parent. So one, to raise that because I've been using the interim to educate my colleagues on that word because I think we lump all those words together and really it's about control. But it's also for our family court judges on ordering these assessments, the ACE assessment, when they're in court because we can't get the kids help if we're not getting that ordered, whether it's a dependency, neglect, or abuse, or if it's in a custody case. And I guess to the point, too, is I've been here for almost 2 years. So my criticism in general is we've gone in a lot of our statutes from a child-centered approach to a parent approach, where we're worried about taking care of the parents and not the child when the parent could actually be part of the problem. So I guess I'm just curious on what policies, besides looking at our domestic violence statute that could work on some of that, what are you all seeing where we can work on that front end in family court?
So being new to this arena, I'm not as clear or educated or informed on the policy. But what I can say in my practice, so I do provide parenting coaching. And the project that I have so far is with a program where the youth are placed in a behavioral spaces for educational, but the parents also sometimes have child welfare exposure. And one of the things that has come from that is the reality that it is a difficult space to be in from a legal standpoint and a policy standpoint because there needs to be outcomes, but in what I've been learning is that maybe the space to grow is in how we wire or phrase the content to where it's being more aware of some of the challenges. And I know that's hard to do legally because sometimes it has to be black and white. But what I've learned in listening and like on the DNA work group is that it boils down to educating and putting the policy and practice on the side of the lawyers and the judges so that they have that awareness. So when the decisions are coming down, there's a decision tree, for lack of a better term, on how you navigate the things you must consider, because parenting is not black and white. These experiences are not black and white. And a lot of things that I think are missing is the day-to-day experiences of parenting. So even to your point about shifting from the child into focusing on the parent, I think the reason for that, and as a clinician, I support that for a couple of reasons. Because from my understanding of what it means to raise a child, it falls on the parent or the caregiver, which is why if you think about it legally, that's why all the consequences come to the parent. So how then do we find a space where we're accounting for the lived experience of the parents and the challenges through the ACEs lens or through the accessibility or barriers to treatment lens, because I'm in a behavioral health space, right? An example I'll give is you mandate that a parent goes to get their child mental health care. Well, as a psychologist, I know that can be up to 6 weeks. What if your mandate says that it has to be done within 6 weeks? So as that example, I can't say that I have the answer, but I think it opens the floor for more conversation about the lived experiences, which is why I sat here today. I wanted to give the lived experience so we can see the details in the inner workings and figure out how to make it to where we're doing accountability, but we're also advocating for getting the child's needs met, because ultimately we all want that. And sometimes moving the parent or putting those parameters around the parent sometimes holds the parent's arms to where they can't support the child.
I would also add that quality legal representation in dependency, neglect, and abuse cases for children, making sure that they have access to quality legal representation is a key part to ensure that their voices are clearly articulated in the courtroom. So at least they have some ability to be a focus there as well. I know that quality legal representation can be difficult with the current reimbursement. And I know it often comes down to money, but in 2026, we may be hopefully having conversations around what it would look like to reimburse our court-appointed counsel for our kids more significantly, because $500 over the life of a case is not adequate.
Thank you. Senator Chambers Armstrong.
Thank you, Madam Chair, and thank you all for the very helpful and insightful presentation. I was curious about what Dr. Goodwin was saying about programs around how we teach parents some of the skills they need to do the day-to-day parenting. I know, for example, my kids' preschool had a really helpful parent education component to it, where it's teaching about things like positive discipline and social emotional learning and all of these things. And I just found it very, very helpful. And I'm wondering about examples of that being scaled or made available and what that looks like to push it out into the community so that it's, I think sometimes these programs are folks who are seeking it out, but the wider community doesn't know about these resources or how to access them. And sometimes there's a real financial barrier to folks being able to access them. So I'm just wondering if there are examples that I could learn from of where this has been done successfully.
Thank you for that question. There are actually a number of evidence-based practices used to teach parenting behaviors, to facilitate how to navigate an environment, help children learn emotional regulation skills, help parents learn how to respond and set up environments that are supportive. PCIT is one of them. To give an example of a more scaled program, as I introduced Parent Zone, I have a curriculum where we start with the parenting identity. It's very group focused. Then we move through to such topics as setting boundaries. Then we move into effective communication. Then we move to effective discipline. So that's an example of an evidence-based practice where sometimes we think about accessibility. We think about stigma around evidence-based practices because evidence-based practices are through clinicians. We think about availability and training of providers. I'm not really sure how many PCIT trained clinicians are in the state of Kentucky, but that would be something that we consider. And then I know for a fact that we have, what do they call the peer supports. So we have the infrastructure to build this out a lot more through the family peer support specialists. So I know that through some of the systems that I've been exposed to, the family peer supports are there to help them navigate child welfare dynamics, right? So that's a great opportunity that Kentucky has to use that as a resource to further train them in the specific skill of parenting.
The HANDS program also comes to mind as well.
Thank you. Okay, we've got 3 more, and we're going to go very quickly because we do need to wrap up. And so I would encourage, if you have a more in-depth question, to maybe the presenters could stay after and have a conversation. That would be very helpful. Representative Rourks.
Thank you, Chair. I just wanted to make a comment that I'm very excited to learn about the cost element to ACEs for the state of Kentucky, how those numbers are broken down, what goes into those factors. But I had a similar question to Senator Chambers Armstrong for Dr. Davis Goodwine, but ultimately, thank you for those resources, and wanted to just also encourage your students, especially since the things that are positive childhood experiences tend to revolve around peer-to-peer and social supports. If they have any ideas of how we can get into a standardized space around prevention and learning what those standardization parenting supports can be even before people become parents, and start making that like we've done with some of the work in colleges around sexual assault and how to be a disruptor in certain situations, especially around alcohol. Those are the types of things that I start to think about the age bracket of when people are becoming parents, and just starting to standardize some of that information so that way we as a community start to grow with those practices more often. But also thank you for the resources that you've already mentioned.
Thank you. Dr. Goodwine and Dr. Moody, I would actually, maybe we could talk about having a field trip. If you're here in Frankfort, an opportunity for committee members to come and visit, maybe after a committee or before a committee on a committee day that we meet in October or November. So I will make sure to touch base with that. No pressure, but really lots of pressure. But I think it would be a really neat opportunity for those of us who are very interested. It really is it's a great conversation, and wraparound services are something I continue to preach about. So thank you. Representative Wilner.
Thank you, Madam Chair, and I love the field trip idea. That sounds wonderful. This material, this presentation, this is kind of where I live. This is material I taught for over 25 years, and you guys did such a beautiful job with it, so I want to thank you for that. My question was also for Dr. Davis Goodwine about how we flesh out and make a reality this framework, because ideally we don't need so many mental health professionals because our systems, our environments are healthier to begin with. And if we're able to train up parents to provide these positive experiences, then that's going to be a huge help. So I won't ask the question since it's already been asked, but I will also add that we did pass a bill last session that made it much easier. Representative Fleming and I worked on this, and the bill passed to make it much easier for master's level psychologist providers to be able to practice much more quickly, to get fully autonomously into the workforce after 2 years of supervision instead of 5. So perfect timing for you in this mission to get your students all trained up and ready for those master's programs. So thank you.
And we are excited to do so.
And last question is for Representative Raymond.
Thank you. I appreciated your all's focus on the positive childhood experiences, which is maybe not new, but newer, I think, to a lot of people. And I've been thinking about ways that the legislature has been investing in those things. And I think the expansion of the HANDS program is an example of us doing that. I think Imagination Library is another example of us doing that. And so I hope we can look to more positive childhood experiences. I wanted to ask you if there's any sort of evaluation tool when we're looking at policy, what it might do to ACEs scores across Kentucky. We've got, when we write bills, we get often a local mandate impact statement. We get a corrections impact statement. Those are the two I can think of. I know in the past people have proposed a racial impact statement or an environmental impact statement. Has there ever been, does anyone use anything like a child impact statement? So when we're looking at legislation that might increase or lengthen incarceration or that might cut public assistance, we could understand earlier on what the impact would be on kids so we can balance that with other goals we're trying to achieve?
We've definitely looked at other states. There's a framework for what is called trauma-informed policy making. So it's not necessarily an evaluation. It is what to consider as policies are developed when it comes to addressing adversity. So that's available, but we can definitely look into and see if there's anything out there around an evaluation. Be happy to follow back up with that.
Thank you. Okay, so our next meeting of the Interim Joint Committee on Families and Children will be on Wednesday, October 23rd, 2024 at 1 p.m. in the Annex Room 149. Thank you all. Thank you all for your fantastic